Hello and welcome to the Auditing Antics podcast. So today we're going to continue the mental health month of May with a discussion about psychotherapy. And this is something that has been very frustrating to me, Michelle, because I can't believe the questions I'm being asked. And
You have shared some with me, and I'm quite shocked as well. So
yeah. Yeah, so to let everybody in on the shocking questions here, what people have been approaching me and asking me lately has been related to wanting to essentially tack on a self-pay charge if the patient has a therapy session that goes over 60 minutes. So for example, if it's 90 minutes, or some have even asked, what do I do if it's 120 minutes? And I had a couple of weeks ago, I think it was when I was in Florida, I had a message come through. So someone who listened to this podcast, which to me it was interesting because we put these episodes out every week. We have no idea who's listening. I can see a little bit of the analytics, but I have to piece it together. It's not very good. So, we
the
put
analytics aren't good, or your ability to
no.
piece it together.
Let me clarify. My ability to piece together is not very good.
Uh,
It's looking good, but I can't see where we're at, essentially. So we're
yeah.
putting this out into the world, and whoever's listening is listening. So I had an email a few weeks back from somebody who is a patient of a practice. So it kind of shocked me. I was like, how did a patient get my email? And they had actually found one of our episodes before,
Mhm.
Michelle, on YouTube, watched the episode, and then started questioning why their practice was trying to pressure them to essentially enter into an agreement where they're saying you need a 90-minute therapy session, but they're pressuring them into essentially signing something and then paying for an additional portion of that encounter above and beyond, the 90837. So, as shocking as that was, then in the weeks after that, I got additional questions, some coming through my membership and then others from some clients. Same exact thing, where there is this workflow in the office. They want to see patients for a longer extended period of time for more intensive therapy, and they want to know how to get paid because the code only goes to 60 minutes. But one of the biggest things to recognize is that the language of the code is referring to 60 or more minutes. So that
Yeah.
doesn't mean that if you are, right at the 60-minute mark or right at that 53-minute threshold or the 2-hour threshold, that reimbursement is the same. The billing's the same. Your revenue is going to be the same. So just because you want to change your workflow, it doesn't mean that that's going to equal extra dollars. And
Yeah.
I just don't understand how, after all of these years, I've never been asked this question before. And now all of a sudden I have a patient asking and three other people asking. It's very odd.
Yeah, and I think I would have to, not that there's any way around it, but I would be curious to know how often is this happening and why is it happening? What
Mhm.
what are you doing in that session that couldn't be planned? Like, you know what you're going into. Why couldn't you make a plan to try to make that fit into, obviously, if somebody's like in a crisis, which there's a whole different billing for crisis that's different, but couldn't you plan to go in and make sure that you work through these important things and, try to stay on track as much as possible, because it's supposed to be that interactive talk
Well,
therapy.
I know what you're saying there, but I think the challenge is when we look at people that have different types of conditions beyond, depression,
Yeah.
anxiety, the typical
Yeah.
thing we would think of. Because some of what does happen if, say somebody has different personality disorders or things like that, sometimes what will happen is a large amount of the time is trying to redirect that patient to stay on
True.
track. So to your point there,
That's
sometimes that
true.
is the struggle, but one
You
thing
don't
that I've noticed in the industry over the years is that if a patient is struggling or if there's something that's more difficult, typically there would be additional sessions added throughout the week. So maybe they
that's
would
what I
come
was just
Monday and
gonna
Wednesday instead of just
say.
Monday.
Why couldn't they add days throughout the week? If they're
Mhm.
needing that more intensive therapy, wouldn't the frequency an increased frequency make sense instead of longer sessions?
Yeah. It
Like,
would make sense, yes. Well, I say that from a coding perspective. I can't say that clinically, so
no.
don't take
And
it that way that way
and
because I don't know clinically.
what you also have to think of, like, payer coverage and frequency that they allow, which I'm sure those are all things that go into it. Here I am sitting in a perfect world saying, "You need mental health help? Well, you come Monday through Friday."
Yeah, yeah. Well,
No problem.
and
You know, like,
yeah,
it doesn't work that way. I realize that. And I also understand, like, things change, like, things aren't always going to be the same. The problems aren't. And I know this even as I audit psychotherapy. A lot of times you're auditing several patient encounters that are of that same patient, and you can see it can be all over the place
mhm,
from encounter to encounter what's discussed. So I guess it's kind of hard to say, can't you plan better?
yeah,
you know?
yeah. Well, in that, so speaking to that for a moment before we move on, there are codes, or there is a code for the complexity, the added complexity. So it's an
Yeah.
add-on code, and that can be used with therapy, and that is there for that purpose. So if there is any kind of struggle related to communication or keeping the patient on track, having to redirect, if
Yeah.
patients are nonverbal and your communication style is different, there are other options, related to an add-on code for that complexity.
And I do see providers trying to use that, but I think the biggest issue I see with that is they aren't documenting what that complexity is. They're not showing
Mhm,
that through documentation, and it's not something that you can build just because it took extra time. You have to
mhm,
show that extra effort during the session. So whether it was, like you said, a communication barrier or some other type of factor, that needs to be clear in your documentation. Don't
mhm.
leave it up to assumption, and don't assume because this is over X amount of minutes, you can add that on. And I would say that is the biggest issue I see with supporting that when I audit psychotherapy is lack of documentation.
Yeah. Well, and along those same lines, let's talk a little bit. I want to break down what we commonly see when we're auditing therapy, but then also
Mhm.
take it a step further when it's therapy with an E&M. But focusing first on just therapy by itself.
Yeah,
So 90832 to 90836, those are the time-based therapy codes.
3-7.
Or 37, thank you. I was just doing add-on today if you
Well,
couldn't tell.
but also in our brains, it's 247.
Oh,
Why
yeah, I
isn't
know,
it 246?
I know, I know, it doesn't flow.
Come on.
But when we're looking at therapy notes, and Michelle, I know we talk about this a lot, there's
Mhm.
a lot of common trends that we're seeing related to either lack of documentation, overuse of EMR smart tools, things
Mhm.
like that. And, it's really becoming a problem because number one, if you look and if you pay attention to TPE audits, payer audits, things like that, they are starting to target therapy based services. Some of
Yeah.
them are more so the add on with an E&M, but I am seeing an uptick in therapy in general. And when we have something like the overuse of the smart tools or the different functions in the EMR, it's it's coming about where we really are having a hard time seeing what's going on in that patient's
Mhm.
life or encounter to encounter.
And that is so true. So many times I'm doing these audits and I'm having to dig through like 15 years of history to try to find what you did today. What is the patient? saying their problems are today.
Mhm.
And I really feel like this is an instance where templates do not help you. Not not templates, but smart phrases, I'm going to say,
Mhm.
instead of a template, because a template can be even just a basic format of a note. But
Right.
we've got to dig through all of these histories and then all of this templated language that has nothing patient specific within it to show us what you actually did.
Mhm. Well, and I think, the challenge when we're looking at the documentation and then if we're having a conversation directly with the practitioner, a lot of the challenge is around situations where the patients maybe therapy is working great for them, maybe
Hmm.
they're being managed well with medication, so it's still needed, but they're continuing to work on the same thing, or the patient's doing really well at that time, so there's not these moments of crisis or these events
No.
that are occurring, and it gets harder for them to think about, okay, how are we going to word this? And, sometimes I laugh because when I'm meeting with them and in audit feedback, I'll say, I know this sounds ridiculous, but from a coding perspective, when we're thinking about making sure things aren't cloned, it really is coming down to you saying this in a different way. You can't use the same language over and over again for this patient, for the next patient,
Hmm.
and, have everything kind of melted together visit to visit.
Yeah, and I think a lot of times it gets lost that psychotherapy is very much so personalized. The
Mhm.
techniques may be the same, but that interactive, how you're utilizing those techniques and interacting with that patient is going to be very much so unique. So I don't really see how you can say the same thing time after time for each
Mhm.
patient, because you cannot tell me that you met with 15 patients today and had the same conversation 15 times. That's just not realistic, especially with a service like psychotherapy. The techniques may be the same, but not the
Well,
actual interaction.
I think some of that plays into the structure of an organization
Hmm.
because when I'm looking at behavioral health based services that take place in person, and,
Hmm.
and I mean looking at documentation, it looks very different than when I'm working with one of my clients that is all telehealth or largely
Yeah.
telehealth. And, it can come down to as well, if we think about the culture within an organization, the workflow, the pressure with the move to the telehealth platform, what I'm seeing is that we have a situation where practices are no longer focusing on in depth, meaningful time with the patient.
Hmm.
And I notice that because I do trainings, for example, with different organizations, sometimes for new providers, sometimes that audit feedback after the results come about from a review. And the providers who have been in the industry for a longer time, who've spent most of their years in person, face to face with patients, are almost going through shock when they join these telehealth organizations because there's this huge push for scheduling.
Yeah.
Everybody's going to have a 45-minute appointment. You have this many minutes in between to either go over if you go over, or you got to finish your note, or you got to work extra hours at night. And I'm noticing that documentation looks very different in those types of
Yeah.
organizations. I'm not going to say anything related to like the quality of therapy or things like that, because I've
No.
even said on our last episode, when I was going through therapy, I was doing that through telehealth and it was great. But the way that they're working and in the environment that they're working in can make a huge difference with what we're seeing in the documentation.
And I think we see it in other specialties as well. I think of like primary care. How, I mean, I was doing work on a provider and looking at their schedule for one date of service, saw 40 patients.
Hmm.
How how do you do that? You know what I
Yeah.
mean? Like, how do you do that and provide quality care. Like the provider, I'm sure, still cares deeply about their patients, but they have little control of them adding patients into their schedule. So it's really unfortunate because I feel like documentation is the area where they're like, what's the minimum we need to do, instead of saying, let me put down what I actually did with the patient today. And I've said it before and I still believe it true. Maybe if we didn't spend so much time trying to use these tools to make our work faster and just
Mhm.
documented what we did during that encounter, we'd be far better off
Right.
from a
Right.
documentation and continuity of care standpoint. Because some of these notes I read, it's like if this patient had a crisis and they went inpatient and they were reading these notes, how would they even know what you did with them?
Mhm.
Or what they like, the goals you have on here have been the same since 2020.
Yeah.
You didn't update them. You maybe updated one, but you know what I mean? So like this copy forward, copy and paste, smart text and things like that really just have done a disservice, in my opinion, to the documentation of
Mhm.
these services.
Well, and one thing that I noticed, so when I work with behavioral health specialties, I do that in different capacities. Sometimes it's directly with a hospital facility that has units. Sometimes it's a psychiatric based hospital, outpatient facility, intensive outpatient, partial hospitalization. And then sometimes it's with larger organizations like the telehealth that I was talking about. And then I
Mhm.
also have clients as well that are small individual practices. And one thing that I consistently hear over and over again, and we hear this across the board with all specialties, but for some reason with behavioral health, they have even less of an idea when they're finishing, their training. When
Mhm.
they're going through, they're finishing their degrees, all of that. I don't know if it's because they talk about it even less in this particular specialty, but I always get these questions about how they will feel lost. Sometimes I'll work with one particular, like a psychiatrist who owns their own practice, and they're like, I'm putting all this information in here because I don't really know what's needed. So
Yeah.
then the notes are really inflated. They're really good. We have a lot of good detail, but it's taking hours to finish documentation. Then on the other side, we have those that are of the mindset that you put as little as possible. And, years ago, I started asking questions of the different physicians and practitioners because I wanted to understand why, regardless of the organization I was working with, there was this huge gap.
Uh-huh.
And one thing that I've largely learned from the providers I've worked with is that when they're going through their clinical training, they are actually told to be very careful as far as what they're putting into documentation. And
Mhm.
I actually had a psychologist years ago who'd been in the industry forever. She kept when there was a EMR system, she kept her own handwritten notes locked in her office and she refused to let anybody see those because when she had gone through training, it was this big thing that you don't put patient sensitive detail related to anything psychiatric into the documentation
Yeah.
that then goes to the insurance. But we have a lot of rules around that. There should be
Yeah.
limited access within a system. We've worked audits before, Michelle, where a client says, okay, we don't just give everybody access to the psych notes. So who on the team do you want to have access to those?
Yeah.
There's different ways of handling it. We have that minimum
Mhm.
necessary standard of access.
Yes.
So I just say all of that because it helps me to better understand when I'm working through the situations. It doesn't change the outcome of the audit where I can say, okay, I understand where you're coming from. Let's support it. We still have got to work on changing and getting more detailed documentation,
Mhm.
but it helps with the approach to understand what happens from their perspective.
Yeah, I agree with that, and I think this is a good time to give that reminder that we have to be so careful what we are reporting on the claim to make sure that it's a definitive diagnosis, that it's supported by documentation, because once that's out there, that can have lasting effects to the patient.
Hmm.
We've all heard those stories of people who've had a diagnosis that's been put out there and then they have trouble with insurance because they see this diagnosis even though they don't have it. It was an error, but
Hmm.
it's on their record. So keep that in mind as well. We have that responsibility to make sure that it's correct. And if we have questions and it's not clear, that we're querying the provider and that they are giving the direction of the specifics and not us. We aren't making the assumption, which
Hmm.
happens a lot, unfortunately. I see a lot.
Yeah, definitely. Now, the other side of this, so separate from the large issue of, typically copy and paste carried forward
Hmm.
documentation with psychotherapy on its own, when we add in the E&M component, there are still so many times where the providers do not understand that the documentation has to be separated. And
Hmm.
before we talk about this, Michelle, I do just want to say this is another area I asked a lot of questions about because I was not always understanding, like, why do you not understand that the HPI is for the medication management only? And we still have to have things separated out with, if that was a part of your intake, you still have to say it with your psychotherapy. And
Hmm.
one thing that I've found is that in a clinical workflow, when we've got medication management going on with therapy, the providers are not sitting there doing everything related to the medication management, then pausing and saying, oh, now we're going to start therapy. So it's all happening at the same time. And what ends up in the documentation that we see when we're auditing is that, the HPI shows everything. It shows how the patient's doing at that
Yeah.
time, shows what they're struggling with, how the medication's working. They're talking about things related to what they're going to review in therapy. And it just becomes this jumbled mess that we can't separate out. And it makes it that much harder to support therapy with an E&M service.
Yeah, another big issue related to this type of billing that I see is I had a client where the providers were just tacking on this time statement saying that 16 minutes of psychotherapy was performed in addition to the E&M, and they were billing like they
Like an
had done
hour.
both. And it's
Yeah.
like, what did you do?
Yeah.
What did you do? And with psychotherapy also being a time-based service, you can't bill both based on your time there. But it was this big mess, and it came down to the fact that they were not documenting the two different services that they were providing. I think
Hmm.
this is an area where a note template would be very
Yes.
helpful, because you could create a template that separates out the work of the E&M from the work of the psychotherapy, and then the provider just fills it out. You know what I mean? Like, that is the purpose of a template
Hmm.
ultimately, not this monster. I'm going to call it a monster that it has become, because some of these notes are insane, quite frankly, with all of this templated language, and then it's lost what you did.
Yeah. Yeah.
Like,
It's a lot of fluff that's happening,
and
unfortunately.
and I think if we sat down and asked, like, I do firmly believe that you should never tell a provider this doesn't belong in your note. Instead, ask why they are documenting it. If
Hmm.
they co- in turn come to you and say, well, this is something clinical XXY, that's not our place. Say, don't put it there. But try to figure out why it's there. Do they think it helps them get a higher level of service? That might save them some time not having to generate that particular phrase in all of their notes.
Well, and that's something that I've done actually. So with the clients that I have that have a smaller, even single sole practice, What I've done is after the audit, when they're feeling overwhelmed, like they're just putting stuff in because they don't know, we've taken time to schedule, half hour. Let's share the screen. You go through, show me how you're documenting, and let's talk about each section. What
Yeah.
does this mean from a coding perspective? What does this mean from a clinical perspective? And we've been able to find different areas that were duplicating what was already being said, that were not needed from the clinical perspective, and then we also didn't need it from a coding perspective. So I have used that particular
Mhm.
approach to help people figure out, okay, what does this template need to look like? But it's very common. I would say the majority of the time that I work with a client for the first time in this space that, has not had prior audits, has not really been paying attention to what needs to be supported with the E&M separate from therapy, it is very common that I see that we don't have therapy supported
Mhm.
because typically the HPI, like I said, is all jumbled together. And then another thing that I see is that there may be a notation, to your point, Michelle, at the end of the note that says, 16 minutes, 35 minutes in psychotherapy. But a lot of times that ends up being a macro statement and it's
Yes.
very generic. And most of the time when I work with clients, they're putting information in their macro statement that says that they were talking about the management of medication.
Yeah.
So it's like if you're educating
Not
the
the
patient
same.
on medication, anything related to medication, that's E&M. So when you put it in your macro statement, we've already got an issue because I can't separate out those differences.
Mhm. That's a really good point because that is seen so often. And I think that's something great to bring awareness to. Any mention to that medication would not be psychotherapy.
Mhm. Yeah, so overall, it's one of those things where you want to take a look at even like a checklist. You can
Mhm.
go into some of the different payers, especially the ones that are focusing on psychotherapy services with an E&M for TPE audits. They will have like Novitas, for
Yeah,
example,
I was
typically
just gonna
has the
say Novitas.
documentation checklist. Yep. So it will tell you these are the things we expect to see for psychotherapy. Just
Mhm.
because it's on the same day as an E&M does not mean that those things still do not have to be in there. So we've got to look at the structure. You've got to look at working together with your providers. If you are a group that does behavioral health services, you need to have an external audit. I feel like
Mhm.
we could say that every single time we finish an episode, but it's extremely important. You need to have an audit because you've got to have the extra eyes looking in from the viewpoint of what CMS or the payers are going to be looking at it from.
Yeah. And I think because these are time-based services, people think if the time is right, that's all we need. But no, your
Hmm.
documentation has to support medical necessity for the psychotherapy. So that's why the audits are so important. Yes, they're
Yeah.
time-based. We even see issues with the time-based billing, to be honest. you
Yeah.
know, where they're off with, those thresholds for billing the different levels or whatnot. But I would definitely recommend checking out Novitas
Hmm.
website because I'm looking right here. They have a psychotherapy services documentation checklist
Yep.
right under their TPE. And they had a lot of other links and resources as well. So even if you're not under Novitas, that's a great place, to start looking to see what is needed, what might be necessary.
Hmm. Yeah, so ultimately, we've got to be able to tell the two apart. And, one other thing too, and you mentioned this a little bit, but I just want to reiterate, remember that when there's an E&M with therapy, the E&M has to be built on medical decision making. So there
Hmm.
will be times, to Michelle's point, that we'll look at an audit and it says that it was 60 minutes in therapy, but we have a 99215 for high risk, and then we have 90836, right?
88838.
Oh, okay. One of these times I'll get it right. from
I
memory.
I have a like I've created myself a sticky note on my computer. You know how they have that little app that
Yeah.
has all of that with time thresholds because I can't remember it. I've
Hmm.
audited hundreds of
Yes.
psychotherapy encounters, if not thousands, and I still have to reference my little sticky note that I have
Yep.
every time.
I do the same thing. I've got the thresholds there, so I don't have to
Yes.
think. So with that, if we've got a level 5 and the highest level psychotherapy code, that's not going to make sense because how did all of that happen? So you don't document time for the E&M, just leave it out completely. The medical decision making will drive that service. And then
Hmm.
psychotherapy time, along with the modalities, what was discussed, all of those details still have to be in there. Lastly, Michelle, do you have any tips? I know typically when I'm doing audit feedback, I'll focus on talking about how the therapy needs to be separated. I prefer to educate that that should be under the assessment and plan. Do you have any thoughts from the auditing perspective as to, when it's easier to identify that therapy separate from the E&M?
I think as long as I think headers are really important in the
Mhm.
documentation itself. While they're not necessary, these are best practices that we're talking about. But having headers to completely separate those and just like your E&M note, like when a patient comes into their primary care, they have to show exactly what they did. You need to show not just the techniques, but that interaction. It's the interaction that supports the psychotherapy. I would
Mhm.
say more than anything. Would you agree? It's
Yeah.
it's just the case. So if you're trying to commingle that all, like don't do it. Keep your E&M separate from your psychotherapy and take a look at the documentation, see what your providers are doing. Because I guarantee you they're not they may not be doing it correctly because I very rarely am able to support psychotherapy in an E&M when I do my audits.
Hmm. And lastly, I want to remind everybody listening too, to that point there, Michelle, even if you are not specifically a behavioral health organization, there are a lot of times now where different practices are integrating these services in because of a shortage or lack of access to care. So if
Mhm.
you're in pediatrics, this could be happening. If you're in family medicine, internal medicine, you want to be aware. If you're a part of a larger organization where you're watching over many different departments, you want to make sure you're paying attention and seeing, okay, is anybody integrating these services in? What does that documentation look like? What can we do to improve and make sure that first the scenario is appropriate and then making sure that the documentation reflects that work that's done.
Mhm.
All right. Well, we'll go ahead and end here for today. And next week, we don't have the topic yet. We'll have it out very soon. But we will be continuing for the month of May, the behavioral health related topics. If you do think of anything, definitely email it in. I said I had a patient email me. If you're a
Yeah.
listener and you're in this industry, we're always open to different topics, different subjects. We'll be doing
Yeah.
another Q&A soon. So feel free to reach out. Let us know what
Yeah.
you think.
You
Have
don't
some
have to
input
be
here.
you don't have to be a compliance professional to say, hey, I would be interested in hearing about this because
Hmm.
I do think there is a certain amount of benefit that comes from understanding how things are supposed to be billed when you are a patient
Yes.
yourself. And I know I look at my doctor's appointments in a very different light than I did before I was in the compliance world. So
Hmm.
there's definitely things we'd be happy to talk about and answer from a patient's perspective, what you should be looking for and expecting.
Yeah. Yeah, definitely. It's always fun to look at it in different ways and have that perspective.
Yeah.
But all right, so I hope you all have a good rest of your week and we will see you back next Wednesday.